All right, good afternoon, everyone. We're going to go ahead and get started here. It's my pleasure to introduce Dr. Hermine Poghosyan. She's an associate professor at Yale University School of Nursing. She received her Bachelor of Science in Nursing from John Coping University in Sweden, and she received her NPH from the American University of Armenia and her PhD from the University of Massachusetts, Boston. Dr. Poghosyan completed a postdoctoral fellowship in interprofessional health services research at the Betty Irene Moore School of Nursing at the University of California, Davis. Her research focus is on cancer epidemiology and survivorship research, with a particular interest in cancer health disparities, lung cancer screening, survivors and their social network members, including families, friends, and others. Dr. Poghosyan is the principal investigator of an NCI-funded R01 that is investigating social networks and affective states in the context of smoking behaviors among adults diagnosed with tobacco-related cancer. Please join me in welcoming Dr. Poghosyan to Yale Cancer Center Grand Rounds. Thank you.
Thank you. Good afternoon, everyone, and thank you, Michaela, for the kind introduction. And I'm very excited to be here today and to share some of my work with you. And I'll be talking a little bit about lung cancer screening in the US and also tobacco use among cancer survivors. So just to give a little bit of a background information, we know that lung cancer is the second leading cause of cancer and the leading cause of cancer-related death in the US in both men and women. And this year, it is estimated that there will be about 236,000 new lung cancer cases and about 130,000 deaths from lung cancer. But when we look at the incidence and the mortality rates for lung cancer by race ethnicity, certain racial and ethnic minoritized groups, they suffer more from lung cancer and they have worse clinical outcomes compared to white individuals. And in fact, African-American men have the highest rate of lung cancer incidence rate and the highest mortality rate compared to other racial ethnic groups. And just for example, one of the studies, our earlier study that we published in Journal of Thoracic Oncology, we found that Black patients who had got surgery for their lung cancer, they had much lower postoperative mental health-related quality of life compared to white patients undergoing lung cancer surgery. And also in terms of survival, there is again significant difference in 5-year survival comparing racial and ethnic minority groups with white individuals. The 5-year survival, the overall 5-year survival, all stages combined, is among all races is 22%. But when you compare, the Black individuals have lower 5-year survival from lung cancer compared to white. And lung cancer has a poor prognosis, and early detection of lung cancer is kind of the key to improve survival among patients diagnosed with lung cancer. And unfortunately, a lot of work has been done showing that only less than 20% of patients are diagnosed with early stage lung cancer. Some of the studies suggest even like 16%, around 16% are diagnosed with stage 1 lung cancer when the more curative treatment options are available that help to improve the survival among these patients. And last kind of 10 years or so screening for lung cancer with low-dose computed tomography has been shown to reduce lung cancer mortality among individuals at higher risk. So one of them well-known, the study conducted in trial in the US National Lung Cancer Screening Trial, showed that screening with low-dose computed tomography decreases lung cancer mortality rate by 20%. And another study recently that came out more recently, Nelson study trial, and from Netherlands, they showed that up to 26% reduction in lung cancer mortality among those who got screened for lung cancer with low-dose computed tomography. And then since 2013, we have a guideline in place by U.S. Preventive Service Task Force recommending annual lung cancer screening for high-risk individuals. And those individuals are asymptomatic adults, ages 50 to 80 years old, and current and former smokers who quit within past 15 years, and they have at least 25 years of smoking history. So this guideline was updated last year to March of 2021. Before the March 2021, the age started 55 years, 55 to 80 years old, and then the smoking pack history was 30 pack year history. So they decreased last year the guideline, the criteria of 20 pack years history instead of 30. And 20 pack years history means that someone smokes at least one pack of a cigarette per day for at least 20 years. And Centers for Medicare and Medicaid Services provides coverage for annual lung cancer screening with low-dose computer tomography for eligible individuals. And Affordable Care Act's mandate private insurance companies to cover lung cancer screening. So one of the main reasons that the screening guideline was updated, to decrease the age and decrease the smoking rate, because a lot of work has been done showing that Black individuals were less often eligible under that guideline for lung cancer screening, despite they have developing lung cancer at much younger age, and they have a lower smoking intensity. So it was hard to meet at least 30 pack years of smoking history criteria. And also they have, like, when you look at the smoking prevalence comparing non-Hispanic whites and non-Hispanic Blacks, they have kind of a little bit like similar smoking rates, but they have much higher, Black individuals have much higher incidence rate from lung cancer, mortality rate from lung cancer. They are diagnosed with much earlier age, and they have lower in smoking intensity compared to whites. So that's why they expanded, kind of changed the criteria with the hope that more racial and ethnic minorities group will meet lung cancer screening criteria, so become eligible. And with that, with the earlier guideline, about studies show that about 8 million adults were eligible for lung cancer. With the new guideline, about 14.5 million adults are eligible for lung cancer. And there have been studies showing that when they changed the guideline, just few came out that more like with the new eligibility criteria, high proportion of African Americans meet the criteria for lung cancer screening. So the current rate for lung cancer screening is very low. The utilization, the uptake of lung cancer screening is very low in the US. The new report that came out about in 2019 was 6.6%, and then 2020, it dropped a little bit to 6.5%. But there have been some studies done, and also our work that showed a little bit higher rate. So but the new report showed much lower rate. That's why I just wanted to bring these numbers here. And a lot of work has been done to show that lung cancer screening rate uptake is much lower among African American individuals or racial ethnic minorities compared to white minorities. But since guideline changed last March, there is still a lot of work need to be done to kind of have that clear understanding of the lung cancer screening uptake by race ethnicity. And there has been reports saying that, estimating that if we implement national lung cancer screening, we could prevent up to like 6,000 deaths in the US. So, but unfortunately, the uptake is very low. So we're interested in this study. So since some work has been done to show like uptake is low, and then the uptake specifically is much lower among racial and ethnic minorities. So we were interested to conduct this study to understand the intention of high-risk individuals to get screened for lung cancer if their primary care provider, if the healthcare providers recommended it. So specifically, in this study, we investigated the association between worry about future health issues of smoking and intention to undergo recommended lung cancer screening with low dose computed tomography within the next 3 months if the healthcare provider recommended it. This was a cross-sectional survey. We conducted the online survey. We used Qualtrics research panel to recruit study subjects. In this study, we included 152 adults aged between 55 to 74 years old with at least 30 years of smoking. So this was part of a much larger study. We had we looked into electronic cigarette use as well, and the total sample size of the original study was 821. And out of 821, 152 who made the criteria of at least having 30 years of smoking. So we used 30 years of smoking because of the prior guideline for lung cancer screening, and the age range we used 55 to 74 based on the national lung cancer screening eligibility criteria. The outcome variable was the intention to undergo lung cancer screening with low dose computed tomography within the next 3 months if healthcare provider recommended it. And the predictor was the worry about health consequences of smoking. And we also collected some covariates as well. We used data to conduct descriptive statistics and logistic regression. So this table shows sample characteristics. Majority of them were about 80% were ages between 55 to 64 years. And about 60% were male. We oversampled racial and ethnic minoritized individuals in our sample. So about 21.7% self-reported as Black individuals, and 42.8% self-reported as white, and 12.5% as Asians. And we had like 25% of the sample were Hispanics. In terms of the income, kind of a little bigger portion of the participants, 36.8%, had the lower than 25,000 annual household income. So we found that majority of the sample, about 86.2%, they were willing to undergo lung cancer screening if healthcare provider recommended it. So, and also found that 67.7% were very much worried, moderately or very much worried about the smoking-related health consequences. So in this table shows the participant smoking history, and the mean PAC years tobacco smoking was 50.8, and the mean number of years they've been smoking cigarette was 44.9. So in the regression analysis, we found that high-risk individuals who were moderately or very much worried about the health consequences of smoking, they were much more willing to undergo recommended lung cancer screening. We didn't find difference by age groups, but we also found that men had much higher odds of reporting willingness to undergo lung cancer screening if they were recommended by their healthcare provider compared to female. And also the interesting finding were the Black individuals, so those self-reported Black individuals at high risk for developing lung cancer, they had much lower odds ratio of reporting willingness to undergo recommended lung cancer screening. And we didn't find differences by ethnicity. So for the conclusion in this study, it was obvious that many individuals at high risk for developing lung cancer, they were willing to get screened for lung cancer. And But the screening by race, ethnicity, self-reported Black individuals had much lower odds of being willing to get screened. And I think like so this was a quantitative study. One of the steps will be, I think, to conduct kind of a qualitative study just to understand why they don't want to get screened. So with this, only we know that, yes, the percentage is lower and they don't want, but I think that we need kind of to go more in depth to understand like why they don't want to get this life-saving screening. And we should have like a public health initiatives to increase awarenesses of lung cancer screening among, specifically among racial and ethnic minorities groups. And there has been some other studies showing that the awarenesses public among general population about lung cancer screening is quite low. So we should do some public health initiatives to increase that awarenesses. So one of the interesting thing for getting screened for lung cancer is the shared decision-making visits. So CMS mandates that healthcare providers have to have a shared decision screening visit with patients, then refer them to lung cancer screening. So during that visit, healthcare providers need to identify if the patient is eligible for screening based on their age and smoking history. And they also need to discuss about benefits and the risks of lung cancer screening. They need to use shared decision-making aid that talks about risks and benefits of lung cancer screening. And during that visit, they also need to discuss about if with current smokers, they need to emphasize the importance of quitting smoking. And if those who are former smokers, they need to discuss the importance of being abstinent from smoking. So we conducted, and I used the study to understand like just rate of patient-provider discussion about lung cancer screening. Is it happening or not happening? And then to understand how it is related to quit attempts. So specifically in this study, investigated the relationship between patient-provider discussions about lung cancer screening and smoking quit attempts among adults eligible for lung cancer screening. So I used this data from the study that I mentioned earlier, like 821 subjects. Out of them, 282 met the criteria of at least 20 pack years of smoking history. So outcome variable was the quit attempt. They tried to quit smoking within past 12 months. And for the predictor variable, participants were asked the question at any time in the past year, have you talked with your doctor or other health professional about having a test to check for lung cancer? So this is the sample characteristics again. So majority were between 55 to 64 years of age, a female 62%, and 26% were identified as self-identified Black individuals, 18% self-identified Asian individuals, and 37% white individuals. And in terms of lung cancer screening, it was kind of surprising to see that majority of them, 84%, did not have discussion with their healthcare provider about lung cancer screening. Even though they were at high, with the new guideline, they are at much higher risk for developing lung cancer screening because we use the 20 pack years criteria to include study subjects. Only 16% reported that they had a discussion with their provider about lung cancer screening. So this table shows participants' smoking history, and about the mean pack year of tobacco use was 39.4, and the mean number of years they smoked cigarette was 44.4. And majority of the participants, 59% of the participants had at least 30 or more pack years smoking history. And 39% of the participants, they tried to quit smoking in the past year. We also asked participants what methods they used to help them to quit smoking. And surprisingly, a lot of them reported switching to electronic cigarette use that with the hope that it will help them to quit smoking. But we know from the later evidence that that's not the case. It doesn't help individuals to quit smoking and stay existent successfully for a longer time. And so in the regression analysis, we found that those who had a discussion with their healthcare providers about lung cancer screening, they're much more likely to try to quit smoking compared to those who did not have a discussion. We didn't find, I didn't find differences by race or ethnicity, and also didn't find the differences in having lung cancer discussion with healthcare providers by race and or ethnicity. So, so one of the main finding that many individuals who are eligible for lung cancer screening, they don't have a discussion with their healthcare providers about lung cancer screening, which is kind of required, mandated by CMS before getting screened. So they have to have the shared decision making. And also, some other research shows that providing education training for healthcare providers about lung cancer screening kind of will help to improve the lung cancer uptake. So having the discussion with patients about lung cancer screening, it helps to kind of improve the lung cancer screening uptake, as well as it will help patients to get motivated to try to quit smoking and maybe eventually help them to quit smoking. So also another way is then people who get screened, there has been another work, including our earlier, so those who actually get to the point to get screened for lung cancer, so they are more motivated to try to quit smoking. So that's why these are kind of very much related. So first, helping patients to quit smoking or referring them to lung cancer screening, so help them also to quit smoking. And so one of the other big part of my work has been focused on understanding tobacco use among cancer survivors. And I used the NCI definition for cancer survivors, and individuals are considered cancer survivors from the time of diagnosis through the balance of life, and their family members, caregivers, friends are all impacted by the survivorship experience, and they're included in this definition. So we know that due to major advancement in cancer screening, early detection, and treatment, so many individuals these days live with a history of cancer diagnosis. In fact, in 1971, about 3 million individuals were living cancer history. And as of January this year, about 18 million individuals are living with cancer history. And it is projected to increase significantly. By 2040, there will be about 26 million cancer survivors. So in order to maximize the overall well-being of this growing population of cancer survivors, identifying their health risk behaviors and helping them to change will help improve their overall well-being. And one of the health risk behaviors is tobacco use, which is still prevalent among individuals diagnosed with cancer. Even though a lot of work has been done and the tobacco use decreased significantly over past 5 decades, still many individuals continue to smoke after their cancer diagnosis. And the prevalence of the tobacco use varies by cancer type. And those who are diagnosed with a tobacco-related cancer, they have the highest rate of smoking compared to those who are not diagnosed with tobacco-related cancers. And we know that continued tobacco use among cancer survivors significantly reduces the cancer treatment effectiveness, and it worsens treatment side effects, it reduces overall survival. It also increases the risk of recurrence and symptom burden, and also it increases the risk of smoking-related comorbidities. And we know that there is evidence-based tobacco treatment guidelines available in the US, and that healthcare providers, that would help healthcare providers to use that, to follow that guideline, to help individuals, smokers, to quit smoking. So the gold standard for tobacco treatment is combining the use of pharmacotherapy and behavioral intervention. And healthcare providers, first, they need to assess and document tobacco use, then provide advice to quit those who smoke, and then assist them with the pharmacotherapy and behavioral counseling. And they also, on a regular basis, they have to reassess smoking status among former smokers to make sure they are still abstinent from tobacco use. And then we conducted this study so to understand how cancer programs are implementing this evidence-based tobacco treatments. So we conduct in this study, we know that from other work that tobacco use still is prevalent among individuals diagnosed with cancer. So in this study, we just wanted to understand more like how this evidence-based tobacco guideline is implemented. And then the results, we found that only 7% of those cancer programs in the Northeast region, they had optimal integration of the guidelines into their delivery system. And only about 39% of this program had a system in place that healthcare providers, they can easily identify, screen for tobacco use, and then document the tobacco use. And also only 25%, they had a system in place that they could easily prescribe pharmacotherapy and refer them to counseling. So all we found that the tobacco treatments were not delivered consistently and routinely among cancer survivors. So, and some of the barriers identified in the work related to not having the optimal strategy in place to identify, to screen for tobacco use and document. A lot of providers, they reported a limited time, so they didn't have enough time to screen for that as well. And then limited reimbursement for clinicians to provide tobacco treatment was also another barrier. So NCI identified as well like that the screening for tobacco use, documenting tobacco use, and treating is kind of hasn't been that well in this country. And since in 2017, NCI launched Cancer Center Cessation Initiative, which was funded part of the NCI Cancer Moonshine program. And the overall like long-term goal of this initiative is that to provide funding to cancer centers and to help them to build and implement sustainable tobacco cessation treatment programs that can help healthcare providers routinely address tobacco cessation among cancer survivors. And since 2017, 52 NCI designated cancer centers received this funding, and Yale's Cancer Center is one of these 52. And there has been some studies already came out showing kind of positive outcome. Those centers who got the funding, that they have the kind of a system in place to identify, to screen and document tobacco use and help smokers to quit smoking. But it's been since 2017, so like I think sustainability should be evaluated so for a longer term to see if it's still moving on. So from my work and from the work of other researchers, kind of we understand how we know that tobacco use is still is a problem, is still common among individuals who are diagnosed with individuals with cancer. So we decided to conduct this study, and it was funded by NCI to understand the role of social networks and affective states in smoking behavior among cancer patients. So I have done some work looking at the role of social networks, and I'm sure you know, like the Yale has a big team who looks at the social network as well. It really shows how important it is to involve your social network members to help to change the smoking behavior or health risk behaviors. But when you look at the intervention side, like smoking cessation programs, those are mostly focused on an individual. And we know that those, if they get a treatment, get a referral, but when they go back home, like get a treatment by get home in their network and someone is in the network smoking, it increases their chance of like starting smoking. So that's why, so with this grant, we are hoping that we can develop social network best smoking cessation interventions for patients diagnosed with tobacco-related cancer. So hopefully we can help them to quit smoking and stay quit for a longer term. So on this grant, I am working with team. I have like really great team, excellent collaborators from Dana-Farber Cancer Institute, Northeastern University, and Dartmouth College. And I have consultants from MGH and University of Pennsylvania. We just started a recruitment. So this is the specific aims. Basically, we want to understand the role of social network members, how they impact the smoking behavior of cancer population. And also we want to know that how the cancer diagnosis impacts on the social network members' smoking behavior. So I have done some work to look into the cancer diagnosis, that it kind of motivates network members to change their health risk behaviors. So this is a mixed method design. The phase 1 we're conducting, it's a quantitative approach. We're using egocentric social network approach to identify tobacco-related cancer, individuals diagnosed with tobacco-related cancer. And then after the phase 1 ended, it's a 1-year follow-up, and we're conducting at baseline, then 3 months, 6 months, and 12 months. And then after the 12 months, we want to do a qualitative dyadic interviews with a cancer survivor and self-identify significant network member to understand how they impact on their health risk behaviors, the relationship. So we just started a screening. We are recruiting from Dana-Farber Cancer Institute, and we have some discussions that maybe later we can open up the recruitment to include Yale Cancer Center as well. So this is just the illustration of the egocentric social network. So basically all information, the ego here represents the individual diagnosed with tobacco-related cancer, and then network members there who they identify. So far, actually, it's going well. And so collecting the social network data is quite rich. And so we are doing via Zoom. So our program manager, clinical research coordinator, they meet via Zoom. So we collect data via Zoom, and so far it's been great, and we'll see how it's going to be. Our sample size is 429. So hopefully we can reach our sample size, and then to see how the role of social network in and the smoking behavior. So this is, I would like to thank everyone that helped me to build my program of research and where I did my education and the team and everyone that I'm working with. And if you have any questions, I'll be happy to answer. Thank you.
Questions for Dr. Poghosyan? We have at least, okay, go ahead.
Congratulations on your R1.
Thank you.
The thing I was curious about, do you see a correlation between either willingness to quit or willingness, willingness to screen, I apologize, or in either of your first two studies with the number of pack years and also with their accuracy of the study, is the risk of getting smoking cancer associated with
So thank you. So for the willingness of the being willing to go to get screening, we included everyone with at least 30 pack years. But I didn't look at by like, are you saying like categorized between 30 to 40, 40, 75? Yeah, we didn't look at that. We didn't look at that. But there have been some work that they look like having the pack year as a continuous variable. So when it increases, their intention also increases to screen from other researchers' work, but we didn't look at that separately.
I actually had a related question to that.
Okay.
So for those, so in your study, you looked at whether or not a conversation with their provider about lung cancer screening then impacted their willingness or their attempts to quit, correct?
Right.
I was wondering if so that was the discussion. I was wondering if there was any idea to look at actual people who actually received lung cancer screening and then whether or not that then directly impacted their willingness to quit.
So yeah, that's actually a good point. That's like, I have like some research project working on, like we have to do like a longitudinal to see if they get if they have the referral, the discussion, then the referral, then the actual screening, if it helps them to quit smoking. So from other works, so that's why like when I saw the literature review we did, people who actually get to that point, who get screened, they're more likely to be motivated and they make quit attempts. But we know that the smoking is like they need to get help. Just trying the quit attempt is a first step, but successfully quit, they need to get help.
Mm-hmm.
So in our study, we just looked only the discussion. We didn't follow up. It was just cross-sectional. We didn't follow up to see if they actually screened. And then if they screened, the quit attempts were higher or lower. And also in that study, I looked on used the updated criteria of 20 pack years. So one of the explanation can be such a low rate of discussion that healthcare providers, they didn't know that the guideline will be changed. So I looked at 20, but the study collected 2017. So it might have been lower. So if the guideline was updated earlier.
So we have a question from the chat from Dr. Silver. She asked, under-resourced patients, poor as well as ethnic and racial minoritized groups, are more likely to roll their own cigarettes due to expense and may be undercounted when it comes to pack years. Any thoughts about trying to capture those who do not buy packs?
So yeah, that's a very important question, and that's a good question. So yes, that's another issue. But in order to the way to measure it, it's very difficult if they roll their own cigarettes. So that's kind of one of the limitations that we're going to miss those population. Just healthcare providers, they have to follow whatever CMS mandates. So first they have to count their tobacco use, then the age, and then meet the guidelines. So that's a limitation. It will be very hard to identify those people who roll their own cigarettes. So one of the requirements that they have to meet to smoke at least 20 pack years of a cigarette. That's the history.
Okay, well, I have one other additional question. This is a pretty big picture one though. So, and that first study that you presented, you said that you found about 86% of the patients the participants had reported a willingness to undergo lung cancer screening. However, like in actual real world practice, that the percent that actually who are eligible who actually do undergo screening is under
Very low.
10%,
Yeah,
correct?
it is. It
Do you
is.
have any thoughts about like what that disconnect is or ways to study it, or even down the road ways to address it potentially?
So, yeah, that's very important. So even though they are willing, I think we have to kind of, so they meet a lot of, there has been a lot of work showing, so they meet, they get discussion, they get referral that they have to screen, and then they don't show up. So like, that's why screening rate is low. And I think there will be like community enrich like programs or like the patient navigators. So I think there should be some system in place that whoever like during the discussion, during the shared decision-making visit, express willingness to go through the screening. So I think we have to have some system in place that we can follow up and to see, did they make the screening or not? So for now, it's high, they won't, but an actual number of last year of 2020 was 6.5%. So those two numbers are very different. So yet, like, we don't have that system to identify, follow up, and bring them back.
And in other, other cancer screening also saw a dip in the 2020, 2021
Yeah,
year
because
because of COVID. So
because
I
of
don't know
the
how much of
COVID.
that could be impacting.
Some states, so that report that I presented some from that, they showed like in some states it was quite stable, and then some states were higher or lower. So it wasn't like across the US that it dropped. There were states were doing much better compared to other states.
Any final questions for Dr. Poghosyan about this important work?
Well, thank you, everyone. So for being here for this time. And I just want to say, like, I'm new at Yale. It's been not new, it's been a year. And I'll be very much interested if we have any similar research interests or areas, I'll be happy to collaborate with any one of you. Okay, thank you. Thanks for coming.
Thanks so much, everyone.